Very good evening, my beloved colleague. Today we can start now and we will not waste our time at all with my humble introduction and from our institute. We hope that we will pass our very good time now until the end of the session. And today our topic is diagnostic approach to skin disease. Especially, we will discuss here diagnostic clinical approach, mainly by looking the patient. In the skin disease, sometimes it is said that the diagnosis is some terminology. That means dermatology is simply nothing but terminology. So I hope that most of you know about the terminology, but we will try to discuss something by describing the terminology of skin or skin appearances, how it will be easily we can reach the diagnosis. Um, if you think that the management of the dermatologic conditions are not too much complicated, for this reason, the dermatology is too much important for the family physician, general practitioners. Definitely, there will be some critical cases where the specialist input will be needed. For this reason, we kept our utmost importance to select the topic from the dermatology today. It will be very basic for all clinical practitioners. So, for example, you can say that it could be used or utilized for the AKT candidate as well as OSCE also, or any clinician throughout the world for any examination also. Though we will not discuss the examination situation, that means the OSCE exam or other exam. We will try to be clinician today more. So let's see. Try to start now with this word primary and secondary skin lesion. Like any other sessions, it will be encouraging for us to interact in the class. So if you feel better, can anyone say me that what do you understand simply by the word primary skin lesion and secondary skin lesion? If you say about something secondary skin lesion, that will be enough. Just to explain secondary skin lesion. Can anybody say? No one? Dr. Shazia?
Like erythema multiforme.
Is it secondary? It is secondary?
It is secondary due to
Some disease.
liver disease.
Yes, yes. In one
Erythema
sense.
nodosum is due to
Ah,
inflammatory bowel disease.
very interesting. Very interesting. Thank you, doctor, for sharing. Just be with me. I will interact with you again, and our colleagues will listen or hear to us. Whatever you said, this is a very basic idea of the secondary, the very word secondary. So if we say about the name of the disease, primary or secondary, name of the disease. So if we say skin lesion, that means the skin appearance. So skin appearance is not the disease. Appearance will help us to diagnose the disease. Dr. Shazia, do you understand? Actually,
Right, sir,
we
yes.
are telling some signs. Lesions means signs. By looking what we are thinking, if I say in advance some words, papular lesion, macular lesion, like that, okay? And
Right, sir.
suppose for scabies, it will be very itchy, is not it? Scabies is very itchy. So scabies, the papular itchy lesion, it will be primary lesion. But after itching, if there is superimposed infection, then infective foci will be the secondary lesion. So now you understand a little different than our general understanding about the primary and secondary. What you explain, it will be understood as primary disease and secondary disease. But in the skin lesion, we are telling if we come across one lesion initially, it is due to problem in the skin, it is primary lesion. But after something happened there, if the another feature comes out in the dermatology, it will be termed as secondary skin lesion. Now, if I show you, it will be very easier for you. Suppose primary skin lesion could be such and such. There is a big list. So we will not read each and every one. You will collect from us later on if needed. And it is available in common books as well. Abscess, barrow, comedon, macule, like that. But over there, for some reason, if skin become as such, skin become atrophied, crusted, excoriated, erosion fissure, scar, sinus formation, stria, ulcer, these are some examples of secondary skin lesion. Okay. Anyway, now come to look at some appearance of the skin lesions. If we say that, we will try to understand some morphology and other features. Initial understanding of such thing, we will later part of today's discussion will be approach to reach a diagnosis considering many issues. So first of all, if we divide the skin disease into three groups, so we can cover most of the skin lesions, the appearance of the skin lesions. For example, skin lesion could be elevated lesion, could be flat lesion, and could be depressed lesions. Within the bracket, you can see that there are some examples given. So now we will like to see now the different appearance of the flat skin lesions. So you see macule patch and the PTC. Macule patch and PTC. There are different appearance of the skin lesions, but one things are common. This is flat lesion. Regarding the difference of the lesion here, we followed one principle is the size of the lesions. If you can see and imagine also now, the PTC is, the size of the PTC is small, but the patch is bigger. So in the books, what we have shown before also, if you go through the book also, you will find the difference between this macule patch and purpura is the size of the lesions. But definitely, there are some other difference like the color of the lesions one. Very interesting. The PTC. So is it simply a lesion like flat lesion, or is there any other message? If we use the word PTC, can anybody say please? Is it simply red spot or some other information is there in the PTC? Can anybody say? Dr.
Sir, there
Shazia?
might be,
Yeah.
sir, there might be some underlying vascular disorder,
Yes, there may
blood
be
disorder.
underlying disease, but in this appearance, we have to say it is PTC or not. That means we have to say this is bleeding or not. If there is bleeding, then we can say it is PTC. Otherwise, we can say only simply macular lesion. So how to differentiate that this is PTC or not?
It will disappear from blanching.
Yes. And what is the name of the test? Clinical test?
Uh,
Glass test.
glass water.
Glass test.
Glass,
Not glass water. Glass test.
glass test.
If you
Sorry,
press by
glass.
the glass, you can see that the red area spots disappear. Then it is not PETCI. Okay. That means the color of the PETCI will not disappear. But as I said you that it could be macular lesion. So look at the down, it also macular lesion. It will also not disappear. Dr. Shazia, can you come forward again? Just to discuss.
Yes, sir.
Suppose
Yes, sir.
this is the macular, it will also not be disappearing. And
Yes.
PTC also will not disappear. So how to differentiate again? This is macula or PTC?
Mm,
I think nobody got prepared to answer this question. No one. Anyway, usually bleeding will be multiple and macular lesion also could be multiple. But as this is bleeding, usually in the disease process, the bleeding does not come in a single time. Bleeding comes in different hours of the day, different days of the week, different week of the month. And as it is extra vesicated blood, the color will be changed. Initially it will be red, later on maybe yellow, and then become darker. So what we could find? We find that the multiple spots are there, they are also of different colors. In another word, it is said as the multiple spots are of different ages. Understand, Dr. Shazia?
yes, sir. Yes, sir. Got it.
Different ages. So, different ages means simply different colors due to resolution of this these spots. You understand this? Any subcutaneous bleeding, there will be hemoglobin. It will be broken down, and then it will be engulfed by the macrophages, and then it will disappear later on. So multiple color and sizes as well. It will indicate that these are of different ages. So these information is very, very important whenever we get any red spot. I hope we will tell a little more also in course of discussion today. Now come to the appearance of such. So what about it? These are elevated lesions. You see, these are elevated lesion. So this is a plaque. These are multiple papules. This is nodule and this is tumor. Only difference nodule and the tumor is the size of the lesions. And these you see, this red color scaly lesion. I'm not telling the diagnosis here. Just simply the name of the skin lesion. We are telling this is plaque. But if it is not elevated, what could we say? Such one lesions. Suppose it is not elevated, appearance is as such. So that means it is a flat. At that time, what will be the terminology? We will telling this is a plaque-like lesion. But if it is a flat of different color, whatever we say, I'm going back. I'm going back intentionally. Suppose this one white lesion. This is flat, bigger size. This is bigger and this is also bigger. Sorry, this is also bigger size. But this is elevated, previous one is not elevated, flat. So these elevated lesion we say plaque. What will be the name of the previous one? Patch. So appearance is bigger, but the terminology is different just by its size. The similarities in the size, but the flat lesion or elevated lesion, considering this thing, we are naming this. This is plaque, previous one is the patch. So whenever we say in the skin, there is an multiple red color, or we can say the pigmented flat lesion, we can say this is the patch, multiple patch. We can say multiple patch. But if it's elevated, so for example, now come to the name of the disease. This is psoriasis. You know, the one type of psoriasis is plaque-like psoriasis. At that time, we will describe the lesions is erythematous, uh, near about the round shape, scaly, elevated lesion. So this is the description. But if we say a plaque-like lesion, this is enough. That means I am shortening my words. So whenever I understand, I utter the word plaque lesion, the listener or audience or in the examiner will understand that we are meaning many messages, that this is like elevated lesion. Okay. So similarly, if it is elevated lesion, but the appearance is projected, nipple-like mass, it will be termed as skin tag. And very often you can heard also, we discussed before also in the last exam, the anal tag. I think some of you can remember anal tag. Okay. Again, these are elevated lesion, but the content of the lesion are fluids. So initial, we are telling this is bulla, this is vesicle, and this is pustule. So here, size is matter though, but important matter is content of the lesions. If the fluid is water only, it is bulla, and if it is in smaller, it is vesicle. But this smaller one, if it contains the pus, it will be termed as pustule. Okay. Now come to the bolus lesions. A little more elaboration is here. So the terminology in the bolus is pemphigus. One disease is pemphigus, another is the pemphigoid. So the bolus lesion could be very superficial in the epidermis. You see this appearance. The immunofluorescence study is done here so that you can understand. But within the epidermal lesions, within the epidermal cells, if the crack there, it will be termed as pemphigus. But the crack between epidermis and the dermis, in between, it is pemphigoid. But we are not going for the electron microscopy or immunofluorescence microscopy. So how to differentiate by clinical eyes, we will discuss later. Now come to again the elevated lesions more than 1 centimeter size containing pus, it will be abscess. But the same thing, if the size is smaller, it will be named as pustule. Pustule. Okay. Again, elevated lesion, but the elevated lesion contain this thing, soft raised, encapsulated. It is elevated, but this is covered by epithelial layer. Encapsulated, filled with semi-solid or liquid content in the skin. It will be termed as cyst. So you know that cyst is available in many other organs inside. But here in the skin like that, this appearance is cystic. This is the milia, small firm white papules filled with keratin. So this is milia. I'm just now proceeding. I think you will understand rapidly what I mean here. So a cavity or channel that permits the escape of pus or fluid. You can remember we said it secondary skin lesion. Sinus will be secondary skin lesion. Why? Before the development of the sinus, there under the skin there is a lesion. For example, like a cyst or a pustule or an the smaller that was abscess. Up to the abscess, we will tell this is abscess, but it is ruptured or somehow punctured. Discharge is coming out from the skin spontaneously, then it will be termed as sinus. The diagnostic value of the sinus is tremendous. Tremendous means by looking at the sinus here, for example, in the neck, it could be the sinus development in the lymph node also. Very commonly, and in our South Asian perspective, the etiology clue is very simple. More likely it will be tuberculosis. Suppose by looking at the neck of this lady, only by looking these, and you understand that it could be as maybe or may not be, even then, as we are in the South Asian countries, we can say more likely it could be tubercular lesion there. Okay. I think you understand this is wheel or urticaria. Appearance is as such. Raised erythematous and edematous papule or plaque. It could be plaque also, you see. Papule means smaller. Plaque is a little bigger size. Already we described before what is plaque. But this is not patch. Remember, this is not patch. So those who don't understand about the skin lesion, there is a unfortunately bad habit that telling everything is macular, papular, patchy, or without understanding anything. So it should not be. Our intention of today's session is uh, uh, as we can pinpoint the name of the lesion. And short-lived vasodilatation. This is part of the history. Short-lived means after talking to the patient, we can understand this is a transient lesion. And this skin lesion actually seen by magnifying glass. The termed barrow is very diagnostic for scabies, like that barrow, linear or curvilinear papule. So these are the papule, but is a linear arrangement suggestive of scabies. Okay. Now come to more elaboration of the red spots. Is very classic difference of this. You see, you can say it could be bleeding, but the very appearance, if you say like a spider, for that we can say spider navy, but all the time this bleeding will not be spider like, only red spot. So I told before about the glass test you can utilize to differentiate this lesion very easily. So if you press over there, the blood will disappear, but this blood will not disappear. And from the PESCI and the purpura, the main phenomena is same. This is bleeding, cutaneous bleeding, but PESCI and purpura again differentiated by its size here. Both are bleeding. Okay. And how it will be very too much important. If I say one disease, one from infectious disease, this is the dengue. And you know, in the dengue, there are multiple skin lesions. These red spots, rather to say, all are not bleeding. So if not bleeding, simply rash, that means erythematous rash, it is not dangerous. It is called exantheme. Many of the viral disease can present with exantheme in the skin. But if it is a bleeding in the dengue, then it will be dangerous. So bleeding will be a warning sign in the dengue. So we must be able to differentiate this. Similarly, in the liver disease, suppose we know the liver disease, spider navy is a very characteristic feature in the chronic liver disease. But in the liver disease, if skin appearance is as such, petechiae or purpura, then we can say there is a development of hepatic coagulopathy. So it will be dangerous. Complication of the chronic liver disease, hepatic coagulopathy. But here it's not coagulopathy, it is just features of chronic liver disease. Traditionally, we are telling one of the features of stigmata of the chronic liver disease. So this is very important differentiating point. Another secondary skin lesions, lichenification. After itching and itching, now you can see how could it be lichenification. Suppose you are looking at different skin creases. Usually you cannot see the skin creases with your naked eye. But after extensive itching and for a long time, the skin creases also become visible and hyperpigmented. This is called lichenification. So accentuated skin fold are there. And the word come out From the another word is lichenoid or lichen planus. Usually, lichen planus is bluish lesions. You can say these are the bluish multiple papular lesions. You cannot identify easily this is itchy or not only by looking the picture or looking the skin appearance. The itchy information is definitely by the history taking. Okay. But there are some other ways also how to identify the itchy lesions. I will show you without asking the patient. Look at this. Is it itchy? Doctor, can anybody say? Is it itchy? The name is Kobner phenomena and disease is lichen planus. Is the appearance telling you that this is itchy? Could be. If somebody itch the skin like that by the fingernails, there will be almost a parallel lesions are there. And the phenomena happening here, the new lesions appear like primary disease. It is called Kobner phenomena. So you already, I think you can remember there are some diseases which produce Kobner phenomena. This is one of that. Another one could be psoriasis also as well. Okay. You can say that straightforward this is psoriasis, plaque-like psoriasis. But the scale we are telling to when we are showing that the what is the name scale telling to us excessive accumulation of the stratum corneum. And this is an if it is a much silvery color, it is very suggestive or diagnostic for psoriasis. This is the scale. Around the mouth, this is called crust. Okay, after the oozing, if the plasma is gone, then the remaining material form the hard materials are there. It is called crust. And it's a very common picture in the AKT exam. We will not discuss the diagnostic difference around. We'll discuss the diagnostic difference a little later. But here, the golden crust is suggestive of a disease. Who can say the name of the disease? Is it written
Impetigo.
possibly? Impetigo. Very good. Very right. Impetigo. Now come to some appearance of depressed lesion. If it is only involving the epidermis, this is erosion or abrasion. Erosion or abrasion. If it is a dip like this, it is ulcer. It is only crack-like, it is a fissure. Nowadays, in the winter season, in South Asian countries now, in many parts, skin become dried and become fissured like that. So we will not say this is ulcer. We will say this is fissure or crack. Another word, crack. But this is ulcer, where the direct damage is there up to the dermis. But here, dermis is intact, only epidermis is broken. So this is erosion, this is ulcer, this is fissure. We will not say this erosion as ulcer. This is excoriation. Just to tell you, I already told before, if there is a linear parallel marks are there, so this picture, this type of picture also can tell us there is an excoriation. So this is a puzzle for you in the AKT exam also. If such picture is challenged to you like that, you can understand that there is an excoriation. I think all of you almost know now that this is a group lesion, grouped multiple vesicular lesions in a group. Okay, one thing is the group lesion. Another thing is location of the lesion, distribution of the lesion. What the characteristic distribution here, if we want to say? Please, anyone?
Dermatomal unilateral.
Yes, yes, dermatomal. Unilateral, yes, dermatomal. So I think you understand all of you the diagnosis of this. Up to this now, we have shown you the different common appearance of the skin lesions. It could be primary lesion, it could be secondary lesion. Now, come to the next topic. Anybody, if you want to ask the question, you can raise the hand or open the mic also, as we are in small group discussion. Otherwise, we are proceeding now. Someone, yeah. Okay, someone open the mic. Please don't feel shy. Just now I saw one mic open. Not now? Okay, no problem. So, how to evaluate the lesion? Only we identified the name of the lesion, but further exploration, further evaluation will be very helpful to reach a diagnosis. Remember, I told the word before, this will be a clinical approach, not by investigating or not by doing any biopsy of the skin. And most of the skin diagnosis is possible without biopsy. For that, we took a challenge now and try to be more attentive. Any disease, we need a detailed history. So in the skin disease, we will follow this chart: onset, progression, duration, many other associated symptom like this, so and so on. Even the family history also important. Can anybody say how family history is important in skin disease diagnosis? For example, can you say one disease where family history is usually present or could be present? Please, anyone? Try to be connected, doctor. Otherwise, you will not understand the significance of the history taking in the skin disease. You will be tunneled vision. How? Only looking the skin and you are trying to give the diagnosis. Sometimes it is not possible also. In this situation, we need help from the history taking. So I'm telling you, and you know the occupation is important. If it is a contact dermatitis, exposure to some irritant material will help us to say this is contact dermatitis. Maybe allergic or maybe irritant. But I'm telling the family history. How family history help us to reach a diagnosis? One disease important. It could be psoriasis. Psoriasis. If you are confused at the appearance of the skin lesion, then if you get the help of history taking, if you got the point that the patient already have the first order relative also have the similar lesions, and the relative also diagnosed as psoriasis, so your patient disease also could be more likely to be psoriasis. The similar thing, as skin is the largest organ, it is the largest organ of the body. Liver disease, kidney disease, so skin also will be diseased, could be diseased, and clinical evaluation basic strategy also same, that I like to mean here. So this is the history detail to know, and in the history the main focus of history is like that. I have told or shown you before, this is the all the areas of any presentation, history taking detail here. From there, you don't think that there are very less points. If you analyze this, there are multiple points are there, 1 2 3, especially in the 3, a lot of messages are there. So from all these things, very, very important, most important points are given there. Already I told you the family history. You see in the point 9, family history. So atopic disease, psoriasis, even the acne also, there is a positive family history. Social, sexual, and travel history also important. It is not only for actually the diagnosis, rather for management purpose in a broader sense, like family physician, social history important, not only for diagnosis. Suppose the notification of the disease, if it is an STD, communicable disease, so we have to save our society also. Whatever, uh, we will try to be focused today mainly for the diagnostic informations. And this is the appearance of the skin diseases, including the nail and the hair. So we should not exclude hair, nail in the dermatology. Even in the diagnostic purpose, we must include the mucous membrane. And another thing, as a practical part for the evaluation of the skin disease, don't forget the musculoskeletal system. So usually in clinical evaluation, we include the hair, nail, mucous membrane, and the joints also for reaching a dermatologic diagnosis or a complete diagnosis. Complete means, already Dr. Shazia possibly said before, that any skin appearance is there, but there may be underlying other systemic disease. Yes, it is very right. And this is a challenge also for a physician, even for the family physician, because if if there is any underlying disease, most of the time we need to refer the case to the specialist. For this reason, we have to consider all other appearance. I like to repeat, skin disease most of the time associated with musculoskeletal features. Okay. Now, this is the main area of exploration or evaluation of the skin disease. Please be attentive and look at this slide. And definitely, I hope you will make a snapshot also of the slide. First headline is the distribution of the lesions. There are many points. Many points. Second point is morphology of the lesions by looking and by feeling. So by looking, you understand that we can see the color, size, margin, and so other. Even the reticulate, lacy network or mesh-like, already we have shown before. So this is the morphology by looking or feeling. And the third point is arrangement. Arrangement. Okay. That is the linear arrangement, circular arrangement. Okay. Or the grouped arrangement, already you have seen before in the herpes zoster lesion. Okay. And the important thing is, especially in the South Asian culture, exposure of the patient. Ideally, patient should be exposed from top to bottom. But you know, in our cultural orientation, we are not used to. So we have to compromise with the cultural understanding, or even we say about the religious understanding also. So we will expose the patient as much as possible. And nails, hair, and mucous membrane should be included, because many diseases have a skin lesion as well as mucous membrane lesion. Many patients have a skin lesion as well as nail lesion as well as hair lesion. We will now show you one after another. So from the three features, we are now taking to discuss about the distribution factors. So no need to remember this thing all, but you just follow with us. First of all, how these distribution, including the hair, help us. I am asking you now, what is the diagnosis of this? If the white lesions are there, we can say this is patch, not the plaque. Flat lesion, patch, but there are bright white lesions, including hairs. What is the diagnosis? Please, please. Anyone, please? Yes.
Vitiligo.
Vitiligo, very right. So this is vitiligo. Hair is involvement. Now again come to the hair. Distribution of the nail. Very diagnostic for the alopecia areata. Suppose you may be confused with this. What confusion will arise? It is alopecia areata or not? What will be the differential will be there in the hair, broken hair in the hairless area? Somebody pull out the hair and broken. What is the name of the disease of the lesion in the hair? Can anybody say? Pulling the hair. Can you remember the word trichotillomania? Trichotillomania. And the appearance may be another name. There may be just only broken hair in the area. But alopecia areata will be like that. And another word you understand, it is called the exclamation mark. But exclamation mark here may not be visible in our eyes. Difficult. So if I get the help of nail, then we can be much more confident to say this is alopecia areata. So what is the features in the nail? Who can say now? In alopecia areata, nobody remember. Nobody. Look at now. What is this? What is this in the nail of the same patient? You still cannot say. In the nail, there are multiple depressions, points,
Fitting.
pitting. So if you can accumulate this feature with this scalp feature, more likely this is alopecia areata. Otherwise, in the absence of nail pitting, it could be traction alopecia, what we described before, traction alopecia. Only simply broken hair. And the treatment also will be different, right? Alopecia areata is an autoimmune disease. And now, Dr. Shazia possibly responded, I remember your name very happily. If it is alopecia areata, it may be part of another systemic disease. Can you say? As it is alopecia areata is in one of the autoimmune disease, what could be underlying other diseases? This is the challenge for the GP to identify underlying systemic disease. Can anybody remember? And definitely this type of question or situation you need to face in the OSCE exam. It could be autoimmune polyglandular syndrome. Have you heard it, Dr. Shazia? Autoimmune polyglandular syndrome.
No, sir.
No? Oh,
No.
try to remember it. And
Right, sir.
it is also part of our practices and even the medicine specialist also. Multiple endocrine glands will have autoimmune disease, and usually in this autoimmune polyglandular syndrome will produce hypofunctional state of the endocrine gland. Hypofunctional. Okay, anyway, so this we are discussing about the nail pitting. Though there are different causes of the nail pitting. Somebody sewing the cloth by the needle, they might have such thing. It is also producing nail pitting. So I am not discussing the nail pitting. Rather, we are discussing about the importance of the skin lesions, how it help in the diagnosis of the disease. Now, this is again one another point of the mucous membrane involvement. Suppose if you look at the skin disease like that, it could be pemphigus or pemphigoid. How will you differentiate? Please respond. Please respond if you can. If anybody cannot respond, no, will not mind. But those who can respond, better to learn. So, will you tell this is pemphigoid or pemphigus? Dr. Shazia, what will you tell it? Pemphigus or pemphigoid?
Sir, this might be pemphigoid.
Pemphi
One involves mucous membrane. I think that is pemphigus vulgaris.
So that I mean, we need to see the mucous membrane also. Where we will see? Suppose inside the mouth, commonly mouth lesions. Now what is the diagnosis? Now you become more confident to say this is
Pemphigus vulgaris.
yes, pemphigus vulgaris. So primarily, the initially patient presented with the skin lesions in the bolus lesion. So as a mucous membrane associated, the diagnosis will be pemphigus. Now look at the face around here. What you are looking there? Is there any involvement of the mucous membrane here? in this appearance? You see
No.
there is again the golden crust, seems to be golden crust. But you see, look at the lips. There are multiple lesions also. Can you see, Dr. Nasir? Look very closely. Skin, angle of the mouth, and you see mucocutaneous junction also there. Is that it? Right?
Yes.
But look at this
Yes.
patient. Is there any involvement of the lips here
Yes,
as
sir.
much as
Yes, sir.
possible? No, no, here. This is only just mucous membrane. This is intact. So, what is the helpful
Margins are
factor?
clear.
What is the helpful factor for the diagnosis here? Is a morphology. Morphology means crusted lesions, but there is also crust. There is could be crust, but the distribution, if we say the inside the mucous membrane or the mucocutaneous area is involved or not, by looking this thing, we are telling this is herpes simplex lesion. We are telling this is impetigo. Okay, now, doctor, it is clear now.
Yes.
So you see
Yes.
almost similar lesion, right, in the face, near about the face. Okay. Now come to this in the face. Already possibly we discussed in our recall session also, those who attended. This gentleman having the face acne-like, but erythematous skin lesions there. Base is very much erythematous, elderly. Though there are some other features also. Anyway, you may not understand it. So more likely this is rosacea. Rosacea. But again, involvement of the eye. Is it acne? Acne vulgaris? No. In the acne vulgaris or in the acne, there is no involvement of the mucous membrane anywhere. But in this skin lesion in the face, there is an eye lesions also. Okay. Neovascularization. It is called ocular rosacea. So, if you find in the face even, patient having the eye lesions also, similarly, easily you can reach to diagnosis of rosacea. It is not easy also. You can remember, somebody definitely will be confused. This is acne or not. But if you found in the eye lesions, it could be rosacea. Even the prognosis of the disease also worse than the acne. So diagnostic challenge is always there. But very interestingly, how we become foolish. Foolish means I am just telling myself. If you think the rosacea as acne, so you are giving the treatment for the acne, but not for rosacea. Interestingly, the treatment of acne will treat rosacea as well. What is our diagnostic outcome? Our diagnostic outcome, falsely we are thinking that we have treated acne, but actually we have treated rosacea. If you go through the book, you will understand. Patient become okay, patient become cured, then we are happy. But this is a false happiness rather to say. Rosacea have multiple outcome also. You see, rosacea can develop in the eyes. So diagnosis is important in this case. Sorry. We are busy with the three feature, remember. Always you will see the three feature. To make it simpler, we actually, rather to say it's by myself, to make the discussion simpler, you may not get this information directly as such. We customized our discussion today. Always, I told in my session that first of all, I tried my best to understand by myself first. Then I disseminate the informations to my colleagues. So it is very almost you can say very personal messages, and the messages are grouped. So I will be happy if you can identify any mistakes. You can guide me, correct me. It will be very useful for me as well, and I will be too much grateful to you. Anyway, so in the three features, come to the distribution in the flexural position. So if it is in the flexural position, who will say the diagnosis now? This appearance, Dr. Shazia?
Sir, eczema?
Eczema. But this is not psoriasis. By looking the flexural position, we can say this is not psoriasis. But though there is some exception, in the exceptional cases, we can see the other appearance of the lesions. Suppose here, for example, I am just discussing for argument. In the flexural area, there is erythematous, plaque-like, and silver scale. What could be the possible diagnosis?
Psoriasis.
Psoriasis. But this type of psoriasis in the flexural area will be very, very rare. Very, very rare. Okay. So the flexural location is helpful, especially for the diagnosis of eczema, atopic eczema. Now you see, in this extensor area, again we can say this is eczema by the contact or other. Though there are silvery appearance, but all the lesions of psoriasis may not be silvery all the time. By the itching and other features, all the features will be gone. The typical feature may not be there. Only remaining issues is erythema, some skin, a little scales are there, not very suggestive for psoriasis. But in this lesion, if we need to differentiate that this is eczema or psoriasis, what we will say in the knee area, Dr. Nasir? More likely we will say this is psoriasis, because psoriasis usually in extensor position, extensor surface of the body parts. Though there may be flexural psoriasis also, remember, this is a little exceptions. So the how position is helpful too much. Another one, especially if it is in the knee and especially for the praying people, maybe Muslim or non-Muslim also, where the prayer culture is bowing down and putting the knee on the ground, the lesion will become more. In that situation, what will be the name of the sign? I think those who are Muslim, interestingly, you can understand. In the praying position, during that we say the Sizda position, we are touching the knees on the ground and the lesions become more. What is the name of this phenomena? Doctor, why intelligently not telling? If the trauma increases the lesion, what is the name of the phenomena? We discussed before today.
Is
Kobner.
it, sir, is it Kobner?
Kilo.
Kobner.
Kobner phenomena. Kobner.
Kobner.
So these Kobner phenomena can happen in the knee lesions. And in that respect also, our diagnosis also will be helpful to say this is psoriasis. Okay, doctor, don't think this silver will be there, silver color will be there always. There may not be. Okay. Now again another distribution. In the face, papular lesion, macular lesion, there might be some vesicle, sometime pustule. What is the diagnosis now?
Acne.
Acne. Acne. So the location of the face more likely to be acne. And now hand, foot, even in the mouth inside, mucous membrane, though I couldn't show you the mouth inside. Nowadays in the South Asian countries, I think, I don't know, have you anyone faced such diagnosis? I have seen few cases in my practice also. Hand, foot, mouth disease. Hand, foot, mouth disease.
Coxsackie virus.
Okay. And the very, very herpes zoster is symmetrical or asymmetrical. Typically, this is unilateral. So unilateral means asymmetrical. So there is no doubt. But the very, very word, if I say bilateral, we need to differentiate this is symmetrical or not. Who can say the difference between symmetrical and bilateral? There are two words. One is symmetrical, another is bilateral. What is the difference? It may not be dermatologic, it may be in the joint disease also. Nobody can try. Suppose these lesion in the right side as such, I'm just explaining Don't think that I am explaining herpes zoster. I am explaining as the word comes now in front of us. Unilateral, there is no doubt. But if such group lesions we find in the right side also, we can say this is bilateral. But if the lesion here in the extent, the same extent and the same morphology in the right side, there is almost no difference, then we will say this is symmetrical. But if there is a difference of the extent, difference of the morphology also, but there are both sides, we will say this is bilateral. It's classically could be explained nicely simply in the joint disease, rheumatoid hands, as well as psoriatic hand. I think you can imagine. So I am not going there. Just to understand, I'm telling what is the difference of symmetrical and the bilateral. So again, here you see, if it is unilateral, this is also unilateral. So by looking at the unilateral word, now you are in a problem to say. Only by keeping in the mind the word unilateral. So what are the difference here? We are looking. This is also unilateral. This is also unilateral. If we want to say what is the difference here, and this is, you know, the diagnosis.
Yes.
This is a port wine stain. This is herpes zoster. But what is the difference here? Though this is also unilateral, this is also unilateral.
There is no raised or group lesions on the port wine.
Okay, one thing.
Evenly distributed.
What distributed, doctor?
Evenly distributed.
Even means flat.
Color.
Yeah.
Flat.
Color is
Color. This is also red. This is also red. You can say that there is no vesicular lesion or other. It is also true. But I want to hear or to tell you, share the message. In the word, the unilateral, okay, this is unilateral, but this is dermatomal, this is not dermatomal. Clear now? Rather, we can say it is according to the vascular distribution. Understand my point, doctor?
Yes, sir.
So rather to say, actually it is a new development in my mind. It is following the nerve distribution. This is following the arterial distribution or the circulatory pathway distribution. Is a new word I like to utter today only. So you see that if I think herpes zoster, the very key word is unilateral, it will not be a good fit for this. Rather, it will be a dermatomal. It is a greatest word for the diagnosis of the herpes zoster, dermatomal distribution. And you can remember also, herpes zoster could be bilateral also in immunosuppressed patient. So unilateral will not be a core word for herpes zoster. Repeating, I am now, the core word is dermatomal distribution. So again, the distribution is taking the lead for diagnosis here. Now, again the distribution, centripetal and centrifugal. Okay, who can understand the word centripetal and centrifugal here? Can anybody say?
centripetal means more in the trunk and pedal more in the lens.
Yes. Centripetal, just look at the picture, otherwise you cannot remember, like me. So more lesions in the center trunk and less lesions in the periphery, the sacral part. You see, more there and the less. It is centripetal and centrifugal. So in the central part having less lesion than the peripheral lesion. Just to differentiate, we have shown. Now the chicken pox and smallpox, suppose. Though differentiation is not very difficult, you see the many papular lesions. Where is the more there? Peripheral part of the body having much lesions, but the central part of the body comparatively has less lesion. It is called centrifugal distribution. So by looking at the papular lesion also, this arrangement can help us to say a diagnosis. Now come to the again another point of distribution is the localized or widespread. If you go through the systemic sclerosis disease, the disease is divided in the classification also, localized and the diffuse disease. It's very easy word now to understand. So one common example of the systemic sclerosis as localized disease is called the morphea. Morphea, like that. You can see in the appearance, morphea. Okay. Now, another part of systemic sclerosis is the thickening of the skin, tightening of the skin. If whole body is involved, then it will say diffuse systemic sclerosis. So one is the localized disease or widespread disease. And whenever we see like this, generalized rash in the body, patient having one disease, we are giving the treatment. So initially we consider this is drug related rash. Suppose you are treating the dengue patient develop rash. At that time, it is very difficult to differentiate this is drug related or dengue related rash. But for other diseases where rash is not a common phenomena, for example, pneumonia, bacterial pneumonia, we are treating the pneumonia by penicillin and patient develop rash. But patient may not develop generalized rash. Rash may be local. If the local rash may be due to the contact dermatitis for something else. But if it's a generalized rash, we can consider this is penicillin induced rash. So widespread lesion help us to diagnose drug related conditions also if it is a widespread. Usually drug related, that is drug is taken by orally or injection, there will be generalized lesion. I don't know how much I'm able to make you understand, please. Please don't feel shy to discuss also or interrupt me if anything is confusing. Now the next point, next headline is the morphology by looking and feeling. So by looking, color, size, margin, elevated, flat, linear, annular, reticulate, how it will be helpful, you can say. You already uttered the word erythema multiforme before. So very characteristic is target lesion. The many targets are there. Erythema multiforme. Very characteristic. So this is morphology of the lesions helpful. Uh, so there are many other types of the skin appearances are there. So one of the color also important. How color is important? Erythema means red color. Black color is the pigmentation. Now again the morphology, how it is helping to us. This is appearance as a morphology is punctate lesion. Punctate. Punctate means, doctor, can anyone remember who attended our previous recall session? We already discussed there on that day in the pictorials. Punctate lesion means centrally depression. You see here in the molluscum contagiosum. Very typical and very gross. But here in the chicken pox, sometime in the central part, a little different. It seems to be depression. The very scientific word we say is umbilicated lesion. Umbilicated. So if umbilication is there, it could be chickenpox, it could be molluscum contagiosum. But the very appearance is the erythema surrounding the papule. Only I'm telling only by looking. I am not asking that the patient having itching or not. It is another history taking helping us. Itching, patient having the fever. These are in favor of the chickenpox, no doubt. But by looking only, that if you see the erythema like that, it is chickenpox. So again, this is the morphology is helping there. Now come to the color. Location is same in the face, but this is black or brown color. This is white color. So whenever the color is the contrasting here, it is chloasma but this is pityriasis alba in the face. So color is helpful. Again color. You see, acne and rosacea already we discussed before. The same thing in the face, but there is an extensive red colors in the skin, diffuse erythema in the face, but there is no diffuse erythema, no extensive redness. Dr. Zainab, please. You raise the hand. Maybe wrongly. Okay, okay. No worry. So this is the acne, this is rosacea. Now size. If you consider the melanoma, malignant melanoma, I think all of you remembered the word more than 5 millimeter, right? More than 5 millimeter size may be a features of the skin lesion of melanoma, cancer. But whenever it's less than 5 millimeter, we say it nevus or mole, general word. But is a bigger. So size telling us, though there are many other features of melanoma in favor, A, B, C, D, E, minimum 5 features. Now again, another feature is the margin of the lesion. So doctor, you understand, we tried our best to gather the picture of the same locations. And I can remember it was not easy for me also to collect the similar features from the sources. So look at, this is the face, this is face, this is red, this is red. So it's the more red though, okay, but we can say this is cellulitis, this is also cellulitis. But in the left side picture, it is erysipelas. So margin is actually helping us to say this is erysipelas. More help we are getting by looking at the margin. What is the margin? The difference between this? There could be also margin and there also margin. What is the difference of these two margin? Please tell now. There is a margin.
Usually,
Sir, it's in erysipelas, it's the sharp, clear margin, and
Sharp, clear
cellulitis is
margin. Yes, it is called diffuse. Margin is not much clear. Margin is not conspicuous. So by looking there, we can say this is erysipelas, this is cellulitis. You know the outcome or prognosis also of this is superficial infection. This is deep infection. So margin is helping. Now we are thinking about these two pictures, the content of the lesion. Suppose the plaque, there might be some plaques also, some papules also. But what content is helping to differentiate these two? You see location also same. Extensor location, this is also extensor location. Same in the elbow. So what content here? I am not telling about the color. You see this is a pink color, this is a red color. I am not asking the color contrast. I am asking the content contrast. What content is differentiating here? The presence of something is there, but this is not present in this lesion.
Scaly nature of the lesion.
Very right. Thank you, doctor. Scaly nature. So wherever the scale, and this is silver scale. So
Yes.
this is psoriasis and this is not psoriasis. Rather, these are actually very difficult to understand as I didn't tell before. Small vesicles are ruptured there, but the location is same in the elbow. One of the vesicular lesions, too much itchy. By itching and itching, vesicle actually gone. So you cannot tell there is some vesicles. This is the natural course of the lesions. But there is no scale, though location is the same. Okay, so content is helping. Another point is elevated and flat lesion. Already we discussed a lot before, right? Someone is papule, could be someone is macule. And here appearance again, we can say by the location and other. What is the diagnosis here? Elderly gentleman in this location, margin is everted, irregular
Basal cell
surface,
carcinoma.
basal cell carcinoma, very right. But I am highlighting here to say about the elevated or flat lesion. The point is elevation or flat. Now,
Papule.
already by the palpation, though we discussed before about two pictures, only by the palpation we can differentiate this is purpura or not. Okay. Though spidery appearance is there, I told before, there may not be a spidery appearance, only red spots. Suppose this patient left side, it could be dengue. Some lesions is not blanchable because it is an erythematous spot only. But some lesions are not blanchable. It will not disappear after pressing. So it is a bleeding. So this is by palpation we are differentiating the point. Okay. Now here, this is also red spots. These are also red spots. A little different, a bigger purpura or bruises like whatever you say. Okay. So only again the palpation. Only again the palpation. There is a left side picture, right side picture. Already it is said as Hannock-Schonlein purpura. Hannock-Schonlein purpura. Palpable, painful purpura. Painful means, that means if you feel there may be tenderness. By the palpation we are discovering there is a tenderness. But here, if it is a purpura, it may not be palpable or may be palpable. So wherever the purpura is palpable, this is due to problem in the blood vessels. You know the mechanism of purpura, defect in the blood vessel or defect in the platelet. Both possible. So if we say this is the bleeding for the idiopathic thrombocytopenic purpura, it will not be palpable. But if we say this purpura are palpable as well as tender also, it could be vascular purpura due to the vasculitis. So this is diagnostic for Hannock-Schonlein purpura, but this is not. But again, if you discover there in this patient, it could be also again Hannock-Schonlein purpura if it is a palpable and the tender and patient complain pain. So it could be also again Hannock-Schonlein purpura, left side. So if not palpable, simply purpura. It is also palpable purpura, but diagnosis is different. Now again, look at the face. Look at the face. Sensation. How sensation can help us? Doctor, who can say? In one patient, there is loss of sensation. Another patient, sensation is intact. Look at this. This is leprosy. This is vitiligo. So where sensation is lost? In which disease?
Leprosy.
Leprosy. It means in the white lesion anywhere in the body, especially in the peripheral part of the body, we need to check the sensation. Suppose we are telling this is leprosy, it could be vitiligo also, may not be too much bright white. Understand, it's a clean cut border in the face. So we need to check sensation. It may be pain or touch, rather by the touch, not pain. Pain is painful. So sensation also a differentiating clinical marker, rather to say, in the leprosy. So two major broad heading we finished. Now come to the third point. Arrangement. Please.
I just have a question, if it's okay.
Why not, please? We always
How to
appreciate.
distinguish in these hypopigmented lesions, and how to distinguish it from something like pityriasis alba?
Pityriasis alba will be, there will not be loss of
Right.
sensation, doctor.
So the history as well, okay.
There, no, I am asking, you just examine pityriasis alba, white lesion in the face. There will
Right.
not be loss of sensation. This is a very standard
Correct.
one. There will not be loss of sensation. Okay. The loss of sensation until proved otherwise, this is leprosy. Okay, remember it. Arrangement. We are discussing about the arrangement now. How arrangement of the lesion help us to reach a diagnosis. All the diseases are not possible to be explained by arrangement. But here, left side one disease, right side another disease. What is the arrangement difference here?
Cleavage line and dermatomes.
We
One
can
is
say In the
Twenty.
right
Which
side, in the screen, the right side, these are dermatomal. One. Another
yeah.
point is a group, is not it? Is not it? It's a group. But
Yes.
here, a little diagrammatic picture also given. What is the
Fir
meaning of that?
it's a fir tree
Fir
appearance.
tree appearance. Wherever the fir tree diagnosis is
Pityriasis rosea.
pityriasis rosea. And wherever the group lesion diagnosis
Herpes.
is herpes zoster. I think all of you know all the materials, but you may not know in an organized fashion of today's discussion. That actually we took the privilege to share with you. Otherwise, you have gone through many diseases and you heard about the description of the diseases. Okay, so try to remember all the messages in organized fashion, that it will be easy. Now again, another distribution. This is a barrow, isn't it? This is a barrow. So barrow means scabies, but this is a stria. And if you take the history after itching, then the new lesion appears. Flexural aspect arising at the site of minor linear trauma. This is due to the trauma in the linear. This is also linear, but this is under the skin. So this arrangement and this arrangement, similar arrangement, but you see there are crisscross, crossing the line each other. But here, this is not as such. But it could be some crossing line due to the scratch in the scabies. Both are possible. But without the scratching, only primary appearance is as such. This is the barrow. So this type of
Yes.
lesion suggestive for scabies.
Sir, if other lesion having a serpiginous.
You can say serpiginous. Serpiginous means curved. Curved. It is not a straight line.
In a larva cutaneum
Maybe,
or
maybe. It is not a straight line. But this is almost a straight line. Why? Because people are scratching in the straight line, right? And we have scratched our skin by ourselves also. We are not scratching the skin like a curvilinear fashion, not a curved line. We are scratching in the linear fashion. So this is the linear one. This is not linear. It is a relatively curved, curvilinear. So this is the arrangement of the lesion.
And sir, excuse me, sir.
Please, I'm going back for you if you want to say.
Sir, what about Koebner's phenomena then?
Doctor, this is not Koebner phenomena in the left side. It is the appearance due to the movement of the mite, scabies mite. Okay, if you scratch there also, there will not be increment of the scabatic lesion. Understand?
Sir, the right one resembles like Cobbler's phenomenon.
Koebner, okay. Suppose there was
Koebner's.
lichen planus 3 or 4 papules. And by nature, lichen planus is much itchy. One of the itchiest lesion in the dermatology. So usually patient itches there, and the itch in the east area where the skin damage is there, there is a new development of the papule. Then it is said as Koebner phenomena. Doctor, did you
Right,
get
sir.
the point?
Thank you, sir.
And I said you Koebner phenomenon also. You can imagine the wart, skin wart. Can you understand now skin wart? If you remove the wart will regrow. And in the more in number. It is also Koebner phenomena. So there are some diseases which shows Koebner phenomena we need to remember. Now here, another arrangement again is a parallel lines. Parallel lines means erythematous parallel scratch mark. So this is a scratch mark. Again the arrangement of the lesion. Okay. Now you are thinking that how much very simple thing we are dealing. No, doctor, it may not be simple in your clinical evaluation sometime. Suppose a patient of chronic liver disease or a patient of jaundice. We differentiate the jaundice by itching. One is the obstructive jaundice, another is not obstructive jaundice. Patient cannot talk to you. Nobody can give the history. Patient is unconscious. At that time, Is there any itching or not? How can you identify? This appearance at that on the skin will be helpful for you. Yes, there is an itching because I am looking, there is a parallel lines. So by clinical eyes, we can say patient developed obstructive jaundice. So today's discussion may not be very simple in situations, in some situations. Same location, both are red, but disease different. How?
Butterfly rash, left side, SLE,
Okay, we
right
can
side
say
to this
this could be also butterfly rash, but
Involvement of nasal folds.
involvement.
yes,
Folds,
this one, this area, this is not involved. Sparing the nasolabial fold.
Yeah.
Nasolabial fold. It indicates what? I'm not
SLE.
telling about the SLE. I'm telling that in the primary skin lesion, what message you are getting? The sparing of the nasolabial fold.
sun,
Sun
sun
exposure
exposure.
affected or not. The nasolabial fold is not affected by the sun because this is just in a relatively covered area. So this is photosensitive rash. But in the left side, it is not photosensitive rash. Why? Because nasolabial fold is not spared. But this is very clean cut sparing nasolabial fold. So it is not photosensitive rash. So a diagnostic criteria of the SLE is photosensitivity. Can you remember? So by looking at the face, one is the mallet distribution, another is the photosensitivity. You got two criteria already there, only by look. So how much strongly helpful to diagnose SLE by looking on the face lesion. But you will not say these patients have the SLE. But we can say there's a malar lesion, but photosensitivity is not there. So in this situation, just we picked up the picture that patient have the diagnosis of the cellulitis. So this you see bilateral lesion. So it is a extensive cellulitis, but this is not cellulitis. This is malar photosensitive rash. Again, something more about the photosensitivity to identify like this. The intelligent eye can identify. If people use the wrist watch, so under the cover of the watch, there is no lesion. Okay. And people are using the long sleeved cloth. So at the margin of the cloth, above the cloth, there is no lesion. But beyond the cloth, there is a lesion. That is photosensitivity. Photosensitivity.
Ring also.
Sorry.
Uh,
Ring.
ring,
Yes. Ring also. Another word you are meaning, doctor, other than ring? Sorry, Dr. Nasir, I couldn't get your point.
sir, you are talking about that the patient doesn't have any problem under the wristwatch. The same happened with the ring finger. Maybe the patient wears the
Yes.
ring.
That ring, under the ring, there will be no lesion because this is covered. Okay? Isn't it? But similarly, if the lesion in the ring area or in the watch area, but other area free, what is the diagnosis?
Contact
Contact
dermatitis.
Contact
dermatitis.
the
Contact dermatitis. This is the intelligence. Okay. We hope we can finish our session today within few minutes now. Something about the bolus lesion. Already we discussed. It may be some repetition also. I told you that I will tell you something more. What I like to say, in our clinical eyes, we are looking some bulla there. That's all. We are not going for the histology. We are not going for that immunofluorescence study. It is only for understanding theoretical knowledge in our practice. Theory means we are not going for the investigation, I mean. So we are having the patient only such bolus lesion. Now question is it bulla or not? One answer you will tell that yes, if it is associated with the mucous membrane in the mouth, it will be
Pemphigus.
pemphigus. Pemphigus. Okay. So There are some history information also to tell this is pemphigoid or not, but I'm not telling in the history. I told you our focus is today only to look at the skin lesion, or at best we can touch. Only up to this clinical maneuver, we will be trying to tell the diagnosis. So, as how the picture is helpful to understand the clinical appearance, for that I put the picture here. For example, we know that the pemphigus, the immunologic reaction happen in the epidermal cells within, in the epidermal cell layer. For this reason, the bullous lesions in the pemphigus are superficial and very prone to be ruptured. Even by the touch of the cloth also it is ruptured. Conversely, pemphigoid lesion a little deeper, in the deeper position. Deeper position means dermis and epidermis, dermo-epidermal junction. In this situation, the bulla may be intact. Very simple touch cannot burst it or destroy it. Did you get the point, doctor? Those who listen now.
Yes, true.
So in real life, if a patient presented to us in this appearance, look at the picture again, without understanding anything else, histology or immunofluorescence or even the history, what we will say, pemphigus or pemphigoid, where the bulla are intact?
We will apply horizontal pressure lights.
No. You will not. How you will damage the skin, doctor? As such, you can find there in the skin, these are busted out, ruptured. But you are looking the picture. What will you say? Is it busted or intact?
Intact.
Intact. If it is intact, it is a pemphigus or pemphigoid. This is the intelligent question.
It's an pemphigoid, I think, because epidermis is
Deeper.
not involved.
Deeper. Yes. This is the logic. This is pemphigoid. Pemphigoid. So in the differentiating point, if you go through the book, you will read many things. Sometimes it is said relatively tense bulla. Tense bulla is in pemphigoid, but very soft bulla is pemphigus. So in our clinical practice, in our clinical eyes, we say that previously it was bulla's lesion. Patient also telling in the history, doctor, I had some vesicle or bulla there, but you are looking there, no bulla is present. So this is ruptured. If in your real life, in the patient, if I don't find bulla there, it is pemphigus. Clear now, doctor? Because this is ruptured. Now a little algorithm to give you expanded messages. Flaxseed bulla, large erosion, or severe exfoliation or skin slough if patient comes to us. Bulla may be pemphigus, pemphigoid, but there may be some sloughing. There may be some other diagnosis also, Stevens-Johnson syndrome, toxic epidermal necrolysis, and staphylococcal scalded skin syndrome. So if you follow these algorithm, you see, if the mucus involvement, already we discussed before, it could be pemphigus, it could be paraneoplastic pemphigus, it could be toxic epidermal necrolysis and Stevens-Johnson syndrome if mucous membrane is there. But no mucous membrane, it is pemphigus foliaceus or staphylococcal scalded skin syndrome. But primarily, initially, bullous lesion means pemphigus or pemphigoid. This is the first thing. But we should not forget about Stevens-Johnson syndrome. Okay. Now you can see that the pemphigus in the two column. Paraneoplastic pemphigus may have mucosal involvement. Clear now? A little difference exception is there. That means pemphigus hardly, rather we have to say the confidently, pemphigus involves mucous membrane, but pemphigoid may involve or may not involve. This is the difference. Okay. And now come to see the lesions. So there are multiple bullous lesion and extensive skin problem. So we are thinking it could be Steven-Johnson syndrome. Could it be toxic epidermal necrolysis, doctor, now? Actually, this is our patient. We made the picture here somewhere. Sorry, not our patient. Sorry. It is a collected picture. This picture is a drug-related lesions. So we are telling this is Steven-Johnson. Why? Can anybody explain?
The skin is intact. In toxic epidermal necrolysis, there will be a lysis of the skin in layers.
Actually, lysis, doctor, if you say like a poet, so you can say lysis, hemolysis. But the lysis word in the dermatology.
Because membrane is involved.
No. Lysis in the dermatology, doctor. So every specialty have different explanation of the terminology. If I tell you onycholysis, what does it mean?
Separation of the nail from
Yes.
the back.
Are we telling that the broken nail or liquefied nail?
No.
No. So in the dermatology, separation. So toxic epidermal necrolysis means there is a necrosis, but separation of the skin from the underlying tissue. So if the separation of the skin is there, then we can say epidermal necrolysis. This is one of the extreme features of the hypersensitivity. So we need to learn the difference between Steven-Johnson syndrome and toxic epidermal necrolysis. There is a difference of the extent of the lesion. It could be toxic epidermal necrolysis. There's a percentage of involvement. Okay. But there should be separation of the skin from the underlying tissue. Then we can say toxic epidermal necrolysis. That means the prognosis is relatively worse than the Steven-Johnson. In general, you know, the Steven-Johnson is self-recovering disease and only conservative treatment is important. Anyway, so look at the appearance of Steven-Johnson syndrome. So don't be afraid. It will be self-limiting, only fluids and other prophylactic antibiotic and a stoppage of the inciting agent, commonly drugs, you have to stop. It will be okay. Now a little approach to the itchy lesion. Simple word. If any patient presented with the itching, okay, you understand now the local itching means contact dermatitis or something else. But generalized itching is indicating a systemic disease. Systemic disease. For example, polycythemia rubra vera presented with the whole body itching, obstructive jaundice, whole body itching. Many other examples we can put. But whenever in the local itching is there, how we are differentiating this? If the local itching is there without any rash, again it may be dangerous. You see, very simple feature, only itching without rash, maybe local or maybe systemic. Usually without rash is systemic, generalized. So investigate for underlying causes. That means there is underlying other diseases. Now come to the other part of the algorithm. Itch with rash. Now you can summarize. This rash may be a secondary phenomena, secondary changes of the scratching. If it is a secondary phenomenon of the scratching, again it come to the right-sided box. There may be again possibility of underlying other disease. But in the history, if we come to know that rash is associated with other skin morphology, that means itch and rash both together in the same time, more likely this is primary skin disease. So in our management, we will focus on the management of the skin diseases. But here we will focus on the management of systemic disease. If we need to refer in the primary skin lesion, primary skin disease condition, we will refer to the dermatologist. But in other systemic disease, we will refer the patient to according to the system. Suppose a polycythemia rubra vera, we will not refer the patient to dermatologist, but patient presented with the itch. So it's a very tremendous effective algorithm for us and easy to remember also, doctor. If I think all of you understood. Now again, already pemphigus, pemphigoid, you see repeatedly coming because we were thinking more for that. So what will be there? It is a pemphigoid or pemphigus. Now quickly please answer. There are 4-5 blister broken also. Even then, by comparison, if mucous membrane is involved, this is pemphigus. Okay, but mucous membrane is not involved. Apparently, intact bulla are more. At that time, we will tell it pemphigus. Sorry, pemphigoid. Tens bulla is pemphigoid. Thank you very much for your participation today, doctor. Best of luck.
Thank you, doctor. Thank you
Thank
so
you
much.
very much. Thank you very much.
Thank you, sir.
Welcome, doctor.